Hi, this is Gary Brooks. Welcome to Orchestrating Health. This morning, I've got a very, someone I don't know, haven't met yet, although I've watched her many, many times. She's part of my personal healthcare orchestra, someone that I've built, that I learned from the experts, Dr. Tara Scott. Welcome, Dr. Scott.
Thank you for having me.
You have been called, I think, the hormone guru,
Yes.
one of America's leading experts on women's hormone and menopause, triple board certified in OBGYN, functional medicine, and integrative medicine. 26 plus years, is that right?
Yes. Yep.
You started young.
Yeah.
So you retired from what I guess we would consider traditional medicine. After some period of time, I've heard you talk about this experience in a conference you attended and experience with your brother and all kinds of stuff. So I'm fascinated with your arc of your career. So talk to us about that. Give us some background on Tara and where you started, how you moved, and where you're at right now.
Yeah. So the short story is I always wanted to be a doctor. So I did medical school and college in 6 years. So at 23, was done with medical school.
Wow.
And yeah. And so, daughter of immigrant parents, right? You either had to be a doctor or an engineer, right? So I was okay. But I'm glad everything worked out well. I loved OBGYN. I loved taking care of women at every phase of their life. And so the first thing that happened was I myself had infertility. So I had to go through all kinds of procedures and medications and everything to get the three kids that I do have. So lots of failed cycles in there. IVF, ended up with twins for the second pregnancy. So that kind of gave me a segue into the world of hormone imbalance. And so the way it is now, and of course this was 25 years ago, after you're done getting pregnant, then there's nothing for you for your hormone issues, right? It's just infertility or nothing. So there's this big vacuum. And so I started learning about women's hormones and menopause right after the WHI came out. So I think we're going to talk about the big study that was published
Yes.
in 2001. And so there was a vacuum where nobody really was recommended to take hormones. And I was able to connect with a compounding pharmacist who took me to a course, and that was in 2003. So I just started learning, and it was just kind of a click for me. It really made a lot of sense. And back then, you didn't have the articles that we have now, the evidence that we have, the resources. So it was kind of like I was swimming upstream in my traditional practice and criticized by my colleagues, but just kept my nose down to the physiology and the science and the evidence. And then, as you mentioned, a few years later, my brother passed away suddenly at 38, and he had a heart attack while he was hiking. And it was a shock, of course. But if as I looked at the data, he had every risk factor. He was a diabetic, he was a lawyer, so he was stressed, right? He was a smoker, he had high cholesterol, he was on a statin, he was overweight. And he was sedentary. So he had every risk factor. He was under the care of an endocrinologist, but to traditional medicine, he was healthy. So to me, that seemed like a big shift. Like I felt like it was a totally preventable death. And so, on top of the hormone expertise I had gained, by that point, I had gotten my certification as a certified menopause practitioner. But it seemed like it was a wider net that really I was called to kind of study and help, like prevent that. For a lot of women, prevent breast cancer, prevent heart disease. So it starts really at the root cause, focusing. So I went on and did my fellowship with the American Academy of Anti-Aging and Regenerative Medicine. So I now teach for them, and then got a third board certification in integrative medicine, which is more like the complementary modalities, more about lifestyle, mind body medicine, acupuncture, that kind of thing. So it's kind of a nice kind of adjunct. And I've been fortunate to teach for their fellowship through the University of California, Irvine. So kind of full circle to try to help other people with this pathway. So right now, I would say, yes, we do a lot with menopause, but I really feel called for a lot of younger women to help them before they get there, because they're the women who aren't getting the attention they need, I think.
Well, I built this health and wellness conference that you're kindly coming to speak at March 9th and 10th. It's really mostly the people that I've leaned into, experts that I've looked at. But I've had this passion for your topic for a couple of reasons. I first got exposed to this 2002 Women's Health Initiative when I read one of Dr. Marty Macary's book before he became FDA chair. And he exposed this, and I was just shocked. I was lucky because my wife was one of the 5% or so that had a doctor who didn't buy into that. And I won't say her age, but I'm 64 next week, and she's not that much younger than me. And she's never experienced any of the things that her friends have, many of them. Her DEXA scan puts her at the 98th percentile of bone density. And so I wanted someone to speak on this topic specifically. I just didn't want to have a summit without this topic being addressed. And so I reached out to Dr. Kevin White, who knew you, and of course made that contact. Why do you think that this is not taught in, the OBGYN practice? There's just no training in that. Why is that the case?
Well, so our OBGYN residency is 4 years, and right now it's still obstetrics and gynecology. So, the first 2 years are very heavy for obstetrics, learning how to deliver a baby, manage obstetrics complications. And I could cut a baby out in a C-section in under a minute, right? In an emergency situation. So that's great. You got to be trained to do anything. And then moving into your third and fourth years, you do have a 3-month rotation in what's called reproductive gynecology, but that's all infertility. IVF, infertility cycles, ectopic pregnancies, some endometriosis. And then, of course, you have your rotations in oncology, but there's really no office-based learning. We do keep a clinic through those 4 years, but most of the patients are coming in for contraception, STIs, birth control, that kind of stuff. Not many of them are coming in with menopausal symptoms.
Mm.
So part of that is the nature of being in a training facility, but part of it is it wasn't in the curriculum. And so, they've done studies that 80% of practitioners feel ill-equipped to treat menopause, and that's in OBGYN. And so I think for anyone wanting to become proficient, you have to do additional training. And if you know anything about training to be a doctor, obviously, like I said, 4 years of medical school, 4 years of residency, specialty on top of that, nobody really wants to go back unless they have a personal, connection to it, or they have a family member who's suffering, because it's a lot of time and money to go back and get more training.
Well, you say you were swimming upstream back then. I've done enough study on this. You were probably swimming against class 5 rapids. I mean, I can't imagine the pressure that you would get 5, 10, 20 years ago saying, hey, wait a minute, I'm not buying into this. So what does it look like when a patient walks into your office?
So now, we've had this whole bloom of social media the last 7 years, maybe. So a lot of them are coming in pre-educated, which is nice. We can put a lot out on social media, YouTube, Facebook, Instagram, and your website. So they can kind of vet their providers and see who is, looking at it. So my typical patient now, probably most of them are between 30 and 55, and they've already kind of been searching, and they've had some issues, they've had some complaints that nobody's been able to put together the connect the dots. Maybe it's migraines that are cyclic, maybe it's an odd kind of symptom like hives that they can't figure out. The majority of our patients are still 45 to 55, wanting hormone therapy, wanting to know the question. And nowadays you have a more exposure to menopause, right? We have all these pop-up telemedicine companies. You can literally go on, fill out a questionnaire, not have a live visit, and get a prescription for hormones from some of them,
Yeah. Hmm.
which I'm glad there is more access, but somewhere in between, should be good. A detailed history an assessment of hormone levels. And if you look at the data and the guidelines, if you will, for men, if men come in and they have complaints, the guidelines are check some baseline hormones, give hormones, and monitor hormones. Even if you're transgender therapy, for example, it's check baseline hormones, give hormones, monitor. But for women, the guidelines are don't check hormones. They vary too much. It's not going to be accurate. And just give hormones. Just guess at a dose based on their symptoms and don't monitor because there's no
Mm,
validity to that. That's the current recommendation for hormone therapy for women.
still.
So still. And so a lot of like I saw a new patient yesterday, she said, I'm just not comfortable with that. I want it to be monitored. And we have a lot of science and a lot of published articles about what levels of hormone in your blood when you're taking hormones are good for bone health, for brain health, for heart health. So we have that data published in our peer-reviewed journals like Menopause, the Journal of Menopause. But I don't know why there's such a disconnect to no one's looking at it, no one's reading it. I mean, I suppose it's just because the amount of time that I've poured into keeping up on this and educating myself about this is a lot. And if you're somebody who's, buried like delivering babies and keeping up with office, you just don't have a lot of extra time.
So my intent is really to help people become partners with their doctors as opposed to just patients. Sounds like you're seeing a lot more educated people come in. Now, the risk, as you well know, there's so much information out there, and not all of it's good information. So speak to my audience about how do you find how do they find people that they can trust, that they can listen to, uh, so that information they're getting, they feel like is somewhat accurate. For me, one of the first things I look for, which has attracted me to you and others in my orchestra, is some humility. People that say, "Hey, we don't know everything. This is what we know today. This is the best information we have now." So, what are the things that you could help my audience in deciphering and weeding through the noise?
Well, you already mentioned one of the first things is that we don't get the training. So don't assume that your OBGYN already knows what to do. You could start there and you could ask them, what's your experience with hormone therapy? Do you prescribe it? What's your feeling? And obviously if you get, oh, I don't believe in it, I don't think you should take it, then you have your answer. So that's the first thing. So it's always got to be somebody who's done additional training. And right now there's a couple of different ways you can get additional training. So the Menopause Society is a traditional organization. And like I said, I've been certified for 20 years from them. They do a lot of research, but the research is about still, we're so behind on research. The research is still about establishing hot flashes are linked to heart disease. Hot flashes are linked to bone, but I didn't find it to be much practical application for hormone therapy. It's more still the definition of menopause and what happens to a woman's brain and what happens to a woman's bones and hearts. So you'll find a provider that is not against hormone therapy, but it will still be a traditional provider that may or may not do hormone levels, may or may not do testosterone therapy. It depends. But at least they won't tell you not to take it. They won't tell you it causes cancer, and they'll be up to the latest research. So they have a directory at menopause.org. So the fellowship that I teach for and did is called A4M. They also have a website. I think it's .org, a4m.com or a4m.org. I'm not sure, maybe .com. They also have a provider directory where you can actually look at the providers, and there'll be a little icon if they have done the fellowship and took the board certification. Like you could be a member, but you may not have done the board certification and the fellowship. So that's what usually I recommend patients to go there. And then you can also, most of the people that have done that type of fellowship are somewhat versed in hormones, although there is a section of that fellowship that is aimed at integrative oncology, and there's one line that's aimed at aesthetics. So it would have to be the hormone track. So that's another great resource. They have a provider directory at a4m.com that patients could use as well. There's another big education for functional medicine called the Institute for Functional Medicine, ifm.org. And I think that's more towards the family doctor, gut, autoimmune. I don't feel though that it has as well hormone education. So I generally advise those first two directories for my people who ask. And then as I mentioned, now with social media, you can vet your provider, look at the credentials on social media. Do they have extra training? Are they a chiropractor who seems very knowledgeable but can't prescribe you anything? So there's the difference between that depending on what you're looking for.
Got it. In November, the FDA removed the black box warning on estrogen therapy. Talk about where that came from and why that was so significant.
Well, that was actually huge. And so I'll just do my 5-minute interpretation of the WHI. So most people don't realize that that study was not done to see if the hormones were safe. That had long been established in the 70s. So the drug that was studied is called Prempro. It's a type of horse estrogen that's collected from pregnant urine of horses, and a synthetic progestin. So two what we call synthetic hormones, although some would argue that horse urine is natural. So that was the number one prescribed medication in the 70s, 80s, and probably into the 90s. And at the time, there were 4 reasons to take hormone therapy. It was hot flashes or night sweats, something called genitourinary symptoms of menopause, which is vaginal dryness, painful intercourse, UTI, prevention of bone loss, and if you have premature menopause before the age of 45. So the study wasn't done to establish safety. The study was done because the makers of Prempro said, we believe our product will prevent heart disease, and heart disease is the number one killer in women.
Mm.
So can we put on our label that you can prescribe this to prevent heart disease? And the FDA is going to say, well, prove to me that it prevents heart disease, right? So they set out to do a study. It had to be a randomized placebo control, which means some people got the drug, 8,000 people got the drug, 8,000 people got the placebo. And the women were around 65. And the reason why it was a later age is because you couldn't be taking a hormone. You couldn't really have any symptoms of menopause. So that led to an older age group. And what they found after 5 years of use is that there was an increased risk of blood clots and an increased risk of breast cancer. And so that was actually, I was in private practice at the time in July, and everyone started calling, and our scientific journal hadn't even published the article yet. It was on Good Morning America. So it was way blown out of control. Everybody said, get off your hormones, no matter if you were 40 with no uterus and no ovaries, or if you were 70, taking it, everybody get off, everyone panicked, and there was really no explanation. But if you look at the data, there was 8 more out of 10,000 blood clots or in your legs or lungs, right? And those were generally within the first year of starting it. But the rate of breast cancer was 3 out of 1,000, so 0.3%. So it really wasn't that much of an increase in breast cancer, but it got blown out of proportion. Now, having said that, we have lots of studies since then that have said, well, maybe taking estrogen through the skin is better than an oral medication. And the difference between that synthetic version of progestin versus the natural that we are now able to make, we weren't able to make it back then. Now we make it from a Mexican yam. And so that is thought to be safer, and the risk is 0.1% of breast cancer. So that is really considered a negligible risk, 0.1%. Right? It's not really hardly causing cancer, but somewhere it's trickled down to causing cancer because they put this black box warning. Now, it didn't matter if you were taking the bioidentical forms, the synthetic form, all of it was the same, and it was labeled causes breast cancer, causes stroke, dementia. And if we prescribed the bioidentical progesterone, which had studies that showed there was no increased risk of breast cancer or stroke or blood clots, they still had that black box warning on there. No matter what it was led to all hormones, which is not really true. That's like saying, if you drink alcohol, you're going to become an alcoholic, so don't drink any. And if you have, we talked about a White Claw versus 5 shots of tequila, it's not the same as alcohol content. And the way my body processes alcohol, probably yours, is a little bit different, right? So every person is different. Every type of alcohol is different, how it affects you. And so you can't really say blanketly if you have a drink, that you're going to become an alcoholic. So that's how it really got blown out of proportion. And that just got passed down year after year after year.
So you mentioned this bioidentical hormone therapy. Without going too deep, for those of us who Just want a broad knowledge of that. What does that mean?
Well, all it means is that it's chemically, structurally the same as what your body is making. So I explain it to my patients like if you had a diabetic patient who had a really low blood sugar and was just about to pass out, would you give them Splenda? Because Splenda has 0 calories, it's an artificial sweetener, and it's not going to do anything to make that patient not pass out, right? That person needs glucose. You'd give them a glucose tablet, you'd give them orange juice because the brain can only use glucose for fuel. So Splenda and sugar are the same. They sweeten your coffee, but in your body, they don't do the same thing. One's a substitute, one isn't. So, what is a bioidentical hormone? Well, now when I was a resident, 30 plus years ago, we used to give diabetics beef and pork insulin. So we'd take the insulin from a pig and we'd inject it. And then some people were allergic to beef or pork, so they'd get rashes. Well, someone in a lab figured out how to make human insulin. They don't take insulin from a patient. They don't have insulin donors take insulin and then give it to another patient. They make it in a lab to be chemically the same as our insulin. So now we have anyone who takes thyroid medicine, that's considered bioidentical, unless you take Armour, which is from a pig. But we have testosterone, that's considered bioidentical. There's not a synthetic version, I think, for men on the market anymore. There used to be methyl testosterone, but so that's this just what a bioidentical hormone is. It doesn't mean it's made in a special pharmacy. An estrogen patch is a bioidentical hormone.
Got it. So the Women's Health Initiative was they were studying women over 60, which means the women who might have been experiencing perimenopause were not even included in this study. So what are the symptoms of perimenopause as women that maybe the doctors are missing?
Well, everyone thinks that the clinical definitions of perimenopause is once your period is longer by 1 week. So women who have regular periods are told they're not in perimenopause, which I guess technically it's true, but it doesn't mean they couldn't have a hormone issue. Because you think if your periods are regular and you have normal bleeding, then you don't have a problem with your hormones. But a lot of women are having sleep disorders, new onset anxiety or panic attacks, depression or low mood. Weight gain is one. I mean, some are having hot flashes and night sweats, but I wouldn't say that's the big one that I see people with. Weight gain is a big one. Brain fog, poor memory, cognition, and fatigue are the most common ones that absolutely can be from imbalanced hormones in perimenopause, and you can have regular periods.
Okay. You've talked a lot about the connection between estrogen and heart disease. And obviously, you've had an experience with that in your family. I had heart stents in 2019. It was my first exposure to, hey, I've got a problem. Didn't know I had. It was also my first experience of going to my experts, my heart surgeon, who I love, and started asking about LP little a. I had an elevated LP little a marker, and he basically said, we don't worry about that. And when I started pressing it, the best answer he gave me, which was a very honest answer, is this, Gary, I don't have a drug for it. You can't change it. You're born with it, and I don't have a drug for it. Well, in 2 years, I dropped mine from 83 to 42.
I was
And
going to say,
so
I've seen it gone down. Yeah.
it began opening my eyes to say, hey, maybe there's more information out there. Help me to understand the connection between estrogen, menopause, and cardiovascular risk.
So we see that, while tragic when we hear about a male at 38 dying, it's not that uncommon. I mean, it's unusual, but it's not unheard of. But you
Right.
almost never hear of a woman before 50 having a fatal heart attack. It happens if you have diabetes or some other medical issue, lupus or something else, but not just having heart disease. So there's been established a protective effect of estrogen while you're still having your cycles. And the Mayo Clinic has done studies on this that they've determined that estrogen in some way protects your heart and your bones, obviously. So if you look at the incidence of heart disease, men are higher than women until menopause, and then women have the higher incidence of heart disease, and it's the number one killer in women. Back in the 70s or maybe 80s, there was actually some studies that they looked at women with EKG changes, so it was ischemia, and they gave them like nitropase, tetrahydrobiopterin, that decreased those EKG changes. But they also gave these women an estrogen patch, and that had the same effect on those ischemic changes on the EKG as this tetrahydrobiopterin did. So they know that there is a correlation with that. And then it also has to do with inflammation that's thought to be plaque. Now, again, as you know, it's not just cholesterol. It's not just that you have cholesterol clogging your arteries. Now it's thought to be inflammation. And that's why we look at those risk profiles. We look at the LDLP and the particle sizes. We look at the ApoB and the LPA, and we look at your risk factors. And it's not just your total cholesterol on your LDL. We look at your ratios, and now we have imaging that we could do a coronary calcium score and a Clearly, which does a soft plaque assessment. So we have a lot more now than we do, but there seems to be this protective effect. And so while that WHI study failed to show that their product could prevent heart disease, right? So they didn't get that indication. There have been observational studies that have shown an improvement. There was just a study published about 7 million women, which is a huge study cohort. Now, it was not placebo controlled, but the women that chose to take hormone therapy, and this was done in the early 2000s, so this is probably still a lot of that Prempro. But there was a 26% reduction in mortality in women who took hormones, and the heart disease being the number one. So there is a connection there. It hasn't been studied and proven by a drug, but we know that even just observationally, women who take hormone therapy have a 19% reduction in diabetes. So diabetes is a huge increased risk for heart disease. So there is correlation either through the inflammation. At the cellular level, estrogen also helps blood flow dilate. So it actually doesn't increase your blood pressure, it decreases your blood pressure. So there's all those things that it's thought to be. Is it the stiffness of the vessel wall? Is it the plaque? Is it the inflammation that causes the plaque? So those are the kind of studies that the Menopause Society is doing to determine that, just like I said, the actual basic science of it. So there's some studies that show the more hot flashes you have, the increased risk of heart disease.
So I had a CT angiogram with Clearly. I've
Okay,
had the
good.
chance of going through that. Amazing technology. Not aware of it being in Oklahoma. I had to go to Texas, so I'm working with Clearly to try to get them in Oklahoma, and have Dr. Osborne will be one of our keynote speakers from Dallas. He's with Claire Cardio, and he'll be talking about Clearly as one of the tools that they use. Just fascinating to me, the technology that's now available that a lot of people aren't even aware of. So you talk about OBGYNs not getting training for menopause. Right now in Oklahoma, we have a lot of women. Unfortunately, you probably don't know this, Oklahoma is either, depending on what year you look at, 49th, 48th, or 50th in the per capita cardiovascular heart disease deaths. So this is a topic that I have personal experience with. I'm going to funerals of friends that I know we could have helped. And so I'm really, really fascinated with this. It's not just a part of aging. What do you say to our friends of mine in Oklahoma about just you really understanding, as well as their doctors, we've got to get a better sense of this?
And I think I can think of 2 people I heard of this week, males in their 50s that died of fatal heart attacks out of the blue. No, fit people who were exercising. So that's where I think that prevention and early detection, we should do a better job of it. And I don't know where that starts from. Is that your primary care doctor? They might be doing lipid panels, or are they doing the advanced lipid profiles? Are they doing the LPA, like you said? Are they doing the ApoB? Are they doing in it where I practice? The coronary calcium score right now is free, but you have to have an order. So it's like there's the University Hospital is doing it, but people don't know about it. And I don't know if the answer is statins or not, but people are polarized on that, on whether or not that will help. But I think part of it is the awareness, and part of it is this movement of prevention. And so whether it is at the lifestyle level diet, exercise. I don't know what Oklahoma's issue is because you guys are southern from us. You must be not as sedentary as we are in Ohio, Northeast Ohio, especially in the winter.
We're pretty
So,
sedentary.
okay, so that's part of the issue. And especially now with people working from home, I don't know if that has been a progress since COVID. So, that's the issue is it the lifestyle? Is it what we eat? I know our food isn't that great. Is it the genetics? Is it the stress? I mean, all of those things are things that affect your risk of heart disease. And so since my brother passed away, I was in my late 30s, I know that I have been a pre-diabetic. And I've always exercised, I've always done sports, I've not had a weight problem ever. I've been bad with my diet when I was younger, but so that's my genetics. I have a Hispanic mother and my dad's from India. Those are two ethnicities that are bad for diabetes. So I have that privilege of knowing that I have that history and making changes because of that. So I would love for people of Oklahoma to know that, maybe to get the prevention, the screening, the simple blood tests.
Do you wear a CGM, continuous glucose monitor?
I've done that before, yes. Yeah.
Yeah. Do you recommend that to some of your patients just to get an idea of what food and drink's doing?
Yeah, we do it a lot to we recommend it a lot for our patients, and we screen with not only a fasting glucose and an A1C, but a fasting insulin. So that's the first thing that will go up before even your glucose does. And also sometimes we do what's called a postprandial insulin and glucose. So some of our patients have a fine fasting sugar, but then it's after they eat that they have a high blood sugar and a high insulin. So depending on what we find, the CGM does measure the spikes in the glucose, so that's great, but sometimes we also have to do the insulin. So we're really involved in that metabolic piece because PCOS or polycystic ovarian syndrome is a hormone condition that women are insulin resistant. So we're working with a lot of those patients. Further, they go on to have metabolic syndrome, which increases the risk of heart disease. So we do quite a bit of the cardiometabolic screening in our practice as well as the prevention.
I was 3 years into my health journey before I really understood how important this insulin score is. And I was surprised it took me that long to discover it and how many when I asked my friends or my wife, I said, "Did you get your insulin score?" Almost nobody gets this. Talk about that just for a minute, because I've become really passionate about that insulin score and how important that is, even more than A1C and some of the other things that we talk about.
Well, there's a couple different ways you can get an insulin score. One is a HOMA-IR, which is a calculated value based on your lipids. I think it's just your lipids, and then there's a calculation. Or there's the Cardio IQ. It's either called an NMR at LabCorp or Cardio IQ, but it's just an advanced lipid profile, which does your lipids and your lipid particle sizes, and then it calculates an IR score and lets you know how are you more likely to be insulin sensitive or insulin resistant. So those are two ways that you can get that assessed.
Yeah, I'm I'm pushing that now on my friends. Get your doctor to get you that insulin score. Very, very important. Back to this black box warning, I've just got a question. It's only been about 4 months, but are you seeing a slow shift? Are you seeing a fast shift within the people that are in your ecosystem and the people that do what you do? How are they responding?
I am seeing, patients that come to see us know I'm a specialist and generally they're wanting to hear about hormones. There are some that come in saying, I don't want to take hormones. I just want to know who mine are. But most of the people that are coming to see us were because I'm a specialist. I'm not doing general gynecology anymore. But I have heard from the patients that come in that their gynecologist or their primary care doctor or somebody even had an ER doctor that referred patients to us. So they are more open and they're more telling patients, well, I think you should think about hormones, but I don't want to do it. Go see this person.
So you speak a lot around the country. Are you being invited more to speak in front of other doctors about this?
Actually, the majority of the speaking that I do is in front of doctors, and that's been the last 15 years. I've been pretty privileged I've spoken in 5 continents. So it's really interesting to see how things are done outside of our country also. Places like Australia and the UK have national health care, so they have some restrictions and guidelines that they're concerned about. But that's what I really enjoy the most, because I feel like if I can go speak to a room of 500 doctors, then they're going to help more people, right? So they're going to learn, and then they're going to help. I can see one patient at a time in my office, and that's a very small ratio of people that I can help. I mean, I do have, and I've trained 3 nurse practitioners at PA. We're going to hire someone else. So I do have an exponential effect in my office, but we can't see everyone. So I feel that the more disciples you bring up, and train, then they can help more people as well.
So I did real estate as a developer for most of my career. The last 8 years, I redeveloped it was the largest redevelopment in Oklahoma State history. It was incredibly stressful, and I did not realize how much stress was probably the primary uh, detractor of my body. I was stress was impacting everything. And so I went to a friend of mine, Jeremy Kubicek, who's one of our keynote speakers. Jeremy's a national bestseller. He's written a book on 5 voices and a book um, about just how chaos our world can be. And so he's identified some areas of our life that create stress. And so I went to him and I said, Jeremy, I'm not so sure if you may not have a piece of the puzzle before I even talk to my friends about nutrition and exercise. How do we calm the stress in their world down? His book, The Peace Index, identifies these purpose and just your the people that you're associated with and job. And so you've really talked about how stress steals those hormones. Dive into that a little bit, because I'm fascinated with what stress does to the body, shutting down our immune system and muscle building. And I just didn't know it. And I don't think most of us are aware of this.
Yeah. And, before the pandemic, I would have some patients that would maybe not have stress, but now it seems like everybody's stressed. The pandemic happened, and then the economy and everything else that's going on. So it's hard to find a person that does not say they have stress, right? So your body is wired, and there's two basic systems. One's the SAM, one's the HPA. That's your body's fight or flight response. In your brain doesn't know if you're running from a bear or if you have a deadline at work, right? The physiological response is the same. Cortisol will go up to get your heart rate up, to make your pupils dilated so you can be alert. It's going to break down your bones to get calcium to fuel your muscles so you can run from the bear, right? It also wants your glucose to go up so it can use that fuel. So in that moment, your brain is going to respond, whether you have a deadline, whether you heard bad news, or whether there were a lot of people that were really thinking they were going to die in the pandemic, right? I mean, it was scary for some people. I didn't feel that way, but there are some people that really thought the world was going to end. So that's a lot of stress on your body. And so cortisol is like a fire in your body. It's only supposed to be life or death stress, right? You're going to run from the bear, and then you're going to have this period of rest and recovery. But that's not actually what happens to us, right? Most of us, thankfully, haven't had a brush with that. But we have these peaks of stress, and then we have this chronic undulating stress with no rest and recovery. And what's also fascinating is now stress can be physical, mental, emotional. It doesn't have to be something you're conscious of. It could be an infection. I've had patients that their mother was pregnant with them, and they lost another child, a sibling of them, so that was a stressful thing that the mother went through while she was pregnant. And this patient was born with a low functioning adrenal system, her whole life, but just didn't know it, because that forms in utero when you're pregnant. And we don't have all that data and the science and the knowledge that we have now. So cortisol has a job to, be the fire to get you into safety. But as that goes on, and chronic stress is defined as more than 24 hours. So, who hasn't had chronic stress? And you move into the next level where your body starts trying to maintain stress. So there's a feedback loop to the brain saying, hey, we got a lot of cortisol. Then the brain thinks, okay, I don't need to stimulate cortisol, but all the rest of the hormones that are made in your adrenal gland from DHEA, those are called anabolic hormones. Those build your body up. your testosterone, your estrogen, your DHEA, there's not a feedback back to the brain for that hormone saying, hey, now we're depleted. So you've got this imbalance of homeostasis that your body is what we call catabolic, is still trying to break down to get the fuel. So that, and what do people do when they're stressed? They don't sleep as much, they don't exercise, they eat crap, they're not getting the fueling they should. Some people eat more when they're stressed, some people eat less when they're stressed. So it really wreaks havoc on you and causes inflammation. So that's the problem.
Which is the driver of most diseases. So I first became aware of this. I was wearing a glucose monitor. I'd done a speech in front of maybe 300 people, most of whom I knew. It was on a topic I was comfortable with. I wasn't even nervous, and I hadn't eaten that morning, and it was a lunchtime, so I hadn't eaten, which is sometimes happens. Intermittent fasting, I'm accustomed to that. And I saw my glucose go from 85 to 150, and I wasn't even nervous. It just, my body was reacting to something like subconsciously that I wasn't even aware of. And it just got me thinking, I lived that way for 12 hours a day for years, thinking this was normal, not realizing it was killing me.
Yeah. And that's crazy. And that's when you hear about the men early morning having a heart attack when they're stressed, because of that. They don't even think about it.
All right. So when I really began diving into my heart problems to try to understand what was going on, I get online and I got on my doctors, but I also found a lot of other experts, cardiologists. And I wake up one day and I'm thinking, half of them tell me LP little a is important, half of them say it's not, half of them say take statins, half of them say don't. And just trying to weed through as a normal average person to try to understand. I've got experts completely disagreeing on almost any topic. So how do you speak to patients, friends, clients, audiences about how do we move through that? We want to trust all the experts, but when they disagree so much, it's really kind of hard to navigate.
I mean, it's really hard because there's a lot in even just my niche of you should take estrogen orally because it's best for your brain. And that's based on 20-year-old studies that they studied oral estrogen and helped the brain. But that's not based on studies that people took transdermal estrogen and still got the same relief, right? So they're hanging their hat on one way to do things, or this is the way to test, only do this type of test. So I try not to operate in absolute. We deal with what's called an N of one, meaning the patient sitting in front of you, right? So yes, maybe I don't have a randomized placebo-controlled trial to tell you that your LPA will decrease, but I have had my patients decrease their LPA as you experienced with some of the interventions. We've used a lot of plant sterols, and we've seen good things for that. So, statins, there's a lot of data on it, but has the statin been compared to other interventions? The statin is decreasing the cholesterol. Is it decrease? It's thought to be anti-inflammatory, but what about other anti-inflammatory interventions? Could that be just as effective? It's hard to do studies with lifestyle intervention because of the funding. Who's going to benefit? The drug companies are doing the studies on their drug, right? Because they're going to benefit. They're going to produce it something. They're going to show the doctors and they're going to prescribe it and they're going to get more people to take their drug. But who's going to benefit if everybody in Oklahoma City now did some intermittent fasting twice a week or wasn't sedentary anymore or cut out processed food? Like, who is going to get the dollars? Nobody. So that's the hard thing to do. So we deal a lot with N of one, like I said, advice for somebody. And I have some people coming into my office that are like, nope, I'm not going to cut out gluten. Sorry. I'm just not going to do it. And I'm just not going to stop working 14 hours a day. And then you have to kind of be thinking about like, okay, where can I meet you? What can you do? Right. I'm not going to force you to do what I think you should do. My job is to be your coach and your encourager and say, here's what the data shows. Here's what I'm concerned about you, but this is what we should do. So it would be nice if everybody kind of approached this space like that and didn't say, there's never only one way to do things in medicine. everybody's body is so complex. I don't know how you could say it's only statins. There's also data that say statins raise your blood sugar. So I don't know that that was the best thing for my brother,
Yeah.
because obviously his blood sugar was terrible. His A1C was terrible, and that A1C is a glycosylated hemoglobin. That's an advanced glycosylated product, which is inflammatory, right? That means there's inflammation and damage to your hemoglobin A1C, so that wasn't good, so I think that for it's got to come somehow to motivate the people, because I think lifestyle choices, and if we educate them, and that's why I spend so much time in social media, because I think if they can't find a provider that can work with them, there's a lot you can do at home. There's a lot you can do by yourself. Look at what you did, right? You did your own digging, right? You have some providers that have helped you, but you also had to do kind of your intervention. Nobody told you how to lower your LPA. So that's maybe where we need to focus on the motivation of the patients and to let them know. I think we're doing a lot better than 20 years ago. People, this generation, this millennials, they're very into self-care, they're very into prevention, they're willing to pay for interventions that are like the gym, the therapy, the whatever, mind body, the yoga. Whereas, my generation still maybe not.
Well, you talk about education, which could lead into the Oklahoma Health and Wellness Summit. It's really a kickoff of what I call a 14-year strategy to move Oklahoma City from the least healthy city in the country to one of the healthiest. And Oklahoma is healthy. Oklahoma City, like Metro, we're either the healthiest or one of them. There are a lot of men. So the mayor and I, for business from local state and county, roll out some of to talk about what's this strategic plan. So I think you said this is your first trip to Oklahoma, right?
Yes.
So
Yes.
I'm anxious to get to share you and your voice with my friends. What would you say to my friends and the people in Oklahoma City about this massive goal that some people have just said, this is a crazy goal to try to move an entire metropolitan 1.5 million people and ultimately 3.5 million people in our state to move from unhealthy to a healthier lifestyle. I think it begins with education, which is why we're putting on this summit. So talk to Oklahomans. Is it possible? Because many of us are going to go, it can't be done.
I think it's a great goal, and I 100% support you in it, as have seen what happened to my brother, which it was totally a preventable death. And so I think you have to find what is going to motivate people, right? Is it going to be the desire to be healthy, the fear of not being healthy? Is it going to be like, I know some of the employers have reduction in insurance costs if you can show that your cholesterol is okay and that you exercise or whatever. When at Cleveland Clinic, I have some of my patients come in and, can you sign this? It has to say my blood pressure, my cholesterol, and then I get a discount on my health insurance. So maybe it has to be a financial goal from your big corporate people there. But because some people don't care about their health, they still don't, they think about them today. They do not think about the future for anything financially, emotionally, and health. That's just their personality. So you'll get some people who want to be healthy because they'll hear stories like yours. And then you'll get some people that just are more in tune, proactive, and they want to do it for themselves, not out of fear, but just out of wanting to be the best, And then you got to hit some people, you got to find out what the pain point is and what's going to motivate them. So I would think getting some kind of corporate buy-in, some kind of discount or something like that would be a great idea as well. I mean, do Oklahomans care that they're 48 and out of 50?
At this point, I would say no, but I believe in my fellow Oklahomans. When I first saw the statistic, I was shocked. I was 62 and I'm looking at them thinking, we're not that bad. Well, yeah, we are. And it woke me up to go to the mayor and say, this is not acceptable. I don't know any of my friends that if I looked at them and said, hey, guess what? We're going to be last in this and it's okay, especially something that's important. And so I just started calling my friends going, did you know this? And all of them said, no, I wasn't aware of it. More people die per capita of heart disease in our state than any state in the country. And they're like, well, I didn't know this. So that's part of my where I'm putting my energy and my focus and any influence I have to say this is not acceptable. We're not going to do this anymore. So what do you hope that people walk away? You're used to talking to, as you said, mainly physicians and trained experts. There will be some of those in the room, but there's also going to be people in that room who have never really even thought about this, which makes it a lot more difficult for giving a keynote, I realize. But what are one or two things that you really hope people take away from your keynote?
I'm excited actually. I like speaking to the public. I think I do a decent job of breaking things down in digestible forms so that people can understand it instead of getting too much in the weeds. Don't get me wrong, I'm going to present some studies, but I'm trying to thin it out so it's not. Today's patient does want to see the studies too. And so hopefully it will be science heavy, but also hopefully at a level that patients can understand and summarize. So I'm hoping that people understand that it's an individual choice about hormones, that they're not automatically thinking, oh, don't take that because you'll get breast cancer. I hope that's the big thing that they'll understand, that they aren't as risky. It's still an individual choice. Like I said, it's an N of one, and it may not be best for everyone. But I hope that they at least think about that. Number one. Number two, I hope that they will also maybe think about like, I didn't realize that maybe these migraines that are causing me to miss work and everything are possibly hormonally driven. So maybe they'll make that connection. And also, I hope that they'll also join you also and me in thinking about prevention.
Well, I tell my male friends one of the best things you could do for your wife is get her involved in this topic. It also benefits them as well
Well,
in their
I mean,
marriage.
that's very true. I mean, research has shown the driver of health is that 47-year-old, the woman, right? She's the one who's doing the grocery shopping, the cooking, and I'm generalizing, right? But she's the one who's telling us we're going to go to this hospital, whatever insurance might dictate that, but she's managing the family, right? So we get the moms to, the wives to come in and they bring their husbands in to our practice because they're feeling better. Now they want their husband to feel better. We see the kids, maybe the teenagers, the 20 something, and oh, you know what? I feel so much better. I think my daughter has the same problem. So I do think you're right. I think your colleagues should tell their wives to attend and have them understand because they've been the ones that have been dismissed.
Well, Dr. Tarscott, so happy to have you as part of our summit. Can't wait to host you at the National. People can find you at drtarscott.com. I find you all over, but we're some other places that people can find you.
I think YouTube is also Dr. Tara Scott, but I'm Hormone Guru on TikTok and Hormone Guru MD on Facebook and on Instagram too. They can find me there. And we do have a lot of free resources at the website, a free downloadable testing guide, an advocacy checklist if you don't know how to talk to your doctor about getting the help you need, and also a free online hormone course for women who are interested, or women or men who want to watch it. So we have a lot of free things on there that we've put together for the public.
I love that. I told the mayor when I presented this idea, I said, if we get half our city healthy, we failed. Not everyone can afford a lot of this expensive stuff that people are doing and biohacking. And so I'm really focused on how can we get free quality education that everyone can have access to. So, well, I can't wait to meet you in person. So happy to get to host you in Oklahoma. I know you've got patients to go see and a practice to run. So really, really appreciate you spending some time with us today. And we'll see you in a couple of weeks.
Absolutely. And I 100% support your initiative. And so I wish there were more people like you that want to be preventative and help others.
All right. Thank you for joining us at Orchestrating Health. We will see you next time.